Okay, so hi, good evening everyone. Okay. Okay, so hi, good evening everyone. Okay, so I'm live now. Just was confirming on my device. Okay, so guys, this is a doubt resolving session of orthopedics, and you are free to ask any question here that you want to. Okay, so I do believe that all of you have already started preparing for your exams. No, so the next target must be an INI or the upcoming NEET examination. So still a lot of confusion about being whether it is going to be a NEET or next, and accurate guidelines are still not out. So many speculations, so many guesses, so many ifs and buts, and still we are nowhere. We are still like in dilemma what exactly it is going to happen. But one thing is for sure, that whatever kind of question it will be just a clinical scenario, isn't it? So what you are expected to do right now is just to keep focused, stay focused on all your preparation, whatever you are studying right now, from wherever you are studying, that is okay. Trust it, have full faith in it, have full faith in your content, in your faculties, and rest of the things can be easily taken care of. So one thing is for sure guys, that most of the questions that we are getting nowadays, they are clinically oriented. So there is no need to get panicked with this word. What exactly is this clinically oriented? You all know, and you have been seeing those things in your clinics. While now after post-COVID, everything is now back to almost back to normal life, and you are back to the wards, you are back to the assisting OPDs and the daycare procedures as well. So you are very much aware that how the things will be asked. Now, if I go back to these last 2 years of the exam papers, whether it is of INI, whether it is of the NEET examination, one thing is for sure. One thing we have seen is that most of the questionnaires that you are facing in your exams, they are most of the things that you usually see in your daily routine ward postings. You're roaming around, you can see the people, the patients having got external fixators applied, some nail applied, some plate applied, somebody having a infection through which the abscess is trickling out of the skin. So all these are the questionnaires which we are getting nowadays. If I take a very recent example of INI, we had this one question, that which of the given 4 fixators is going to give you the maximum stability, right? So there was a question regarding the stability part. So which of the external fixator, and the options they have given over there, they were somewhat like one of the option I remember, it was Elizaro. One of the option was Elizaro which was given. Another option was that was a simple rod and clamp. So they said that uniplanar, one side, the uniplanar rod and clamp. Then they said that uniplanar, it was a single rod. Then they said uniplanar double rod, single rod, and then they said double rod, and then they said that there is a biplanar rod and clamp. So that's how they ask you the question. Now if you apply some logic, obviously uniplanar on one side of the bone, biplanar will be obviously on two sides of the bone, so like that, and Elizaro is all around. Which of the given ones you think is going to give the maximum stability? Like the Elizaro one, isn't it? So what I'm trying to say is, most of the things in your exams have been like clinically oriented, okay, and you have to just apply some logic. So in your exams you usually get two kind of questions. One which are basically factuals, facts. One which are based on concepts. So my idea is always to focus on the concept. Once you focus on the concept, it will be little easier. If you have not even read some of the topics, some of the questions, some of the content, it is easier to answer the things. That is what I believe in, right? Factual things, if you don't know something, somebody else also don't know that thing, right? So factual is, if you have not even heard of it, if you have not, like if I tell you one simple question from orthopedics which was asked in last session of examination, it was in INI 2020, where they asked about the fish tail deformity is seen around which joint or which bone. So fish tail deformity is seen around which bone? Now for last 2 years everybody has been teaching that fish tail deformity is seen around the lower end of humerus, and the concept of which you may read secondly. But yes, you must be, these are factual things which if you don't know, you cannot answer it very, very simply. So facial deformity is seen around the humerus. Similarly, they asked you a question about the Hageland's deformity seen around which bone. So Hageland's deformity, it is seen around the calcaneal bone. So Hageland's deformity like calcaneum. So what I'm trying to say, there are things which you can easily solve by a simple logics, by applying simple, staying cool and calm in the exam, applying some simple basics and factual things or conceptual things, mixing them up, you can easily come to some answer. That is what I wanted to say. So today, I wish to just discuss with you certain, the file of splints and traction, which has been requested by the students on the eGurukul app, that please show us the different types of splints, please show us the different types of the traction systems, how to apply them, how to utilize them. So just we are going to discuss this file with you. So I've got this file with me, the splints and tractions. Okay, so I'll be discussing this file only with you today, and it is going to be an interesting one, it is going to be an important one, and you all know. Please show us the different types of the tractions. Yeah. Okay. So now I'll just be okay. So the file, guys, this is a file which is already there in your eGurukul app. If you wish to just discuss this, you can open up that app as well. So this is the first table that you can see in this particular file, which is available on all the social media platforms, on all the DBMCI Premier group, on the regular batch, intern batch, post-intern batch, my orthopedics group, Sushil orthopedic discussion group, like that. So this is a file available as PDF, PPT on different Telegram groups. So what all we can remember from here? So these are the different splints, like Thomas, you all know, it's used for fracture shaft of the femur. So femur shaft. Dennis Brown splint, you know that it is for CTEV, the congenital telepacic varus. Mermaid splint we can use in the varus or valgus deformities of the knee, basically legs area, for the rickets patient. Cock up, knuckle bender, aeroplane, you have read about these. Okay, how do they look like? Let's talk about that. So the first one, guys, I'm going to talk about it is the Thomas splint. Right, this first image that you see is the Thomas splint. What exactly is a Thomas splint? Where do you use it? So it was designed by the Thomas splint. It was designed by H.O. Thomas, and H.O. Thomas designed this for his wife who was suffering from tuberculosis of the knee. So basically, to stabilize the tuberculosis of the knee, he developed this design. Okay, in this design, nowadays we are using this design to stabilize the fracture shaft of the femur. If you want to transport the patient, if you want to stabilize the bone for the temporary phase, or if you want to have this stability till the patient can decide what exactly he wants, so we can use it. This upper ring, you see, it is not parallel to the ground, it is having some inclination. Okay, and this inner bar basically is having an angle almost of 120 degrees with the parallel ground. So this is not a flat ring, this is an inclined ring, and on the inclined ring, on the outer surface, outer side, you must say, there is an angulation, and this angle is basically to accommodate the greater trochanter of the femur, right? So this basically is what you call as Thomas splint. Nowadays we are using for fracture shaft of the femur. This one, the second one you see here, is the Mermaid splint, which we can very well use for, as I said, the cases of rickets, the children who are having the genu varum or the genu valgum deformities, maybe nutritional, maybe since birth they are having the deficiencies. So you can apply them all along the long axis of the leg, and as the child grows, gradually the legs will become straightened. So Thomas splint and the Mermaid splint. Next one we have is this splint, which is what you call as the Taylor's brace. This one is what you call as the Taylor's brace. What exactly is a Taylor's brace? Taylor's brace is a kind of splint support, you can say. This in front is the Velcro. Okay, this in front is the Velcro, and on the back these are the aluminium splints here. So because of these, the patient basically cannot bend forward, the patient cannot flex. And why are we giving it? We are giving it for the dorsal spine stabilization. We are giving this Taylor's brace for the dorsal spine stabilization. In what all cases would you like to give this Taylor's brace? Whenever you don't want the patient to bend forward. For example, somebody had an injury and there is a compression fracture of the vertebra. So if there is a compression fracture of vertebra, we can very well use it. So if there is compression fracture of vertebra, we can very well use it. You don't want the patient to have a load on the injured vertebra. So it can keep, like osteoporotic collapse, we say, compression fracture of vertebra in osteoporosis, we can use it. If there is a traumatic injury, we can very well use it. right? If there is some tuberculosis infective foci on the vertebral body, we can use it. So this is Taylor's brace for stabilizing the dorsal spine. Okay. Next one I'll show you is this one, which is what you call as Milwaukee Brace. Now here you can appreciate that this child is having a curvature deformity here on the back, right? That is what you call this? This is what we call as scoliosis. So this Milwaukee Brace is used for children's for the cases of scoliosis. And how it works, you can see the pressure here on the chin area, on the pubic area, occiput area, iliac area, like that. Okay. So when the child is growing, you keep on increasing the traction. So as the traction is increased, the child can very well, as the child will grow with traction, it is presumed or it is seen that the spine, basically the vertebra column, it starts getting straightened. Okay, that is what why you use Milwaukee. This is in children, and its counterpart that we talk about in the adult age group, basically the counterpart which is used is known as Risser's cast. It is known as the Risser's cast. So adolescent ones, it is a Risser's cast. Okay, so Milwaukee and Risser's, and then you have something like Boston brace as well. These are used in the adolescent or the adult age group. So Risser's cast, Boston brace, Milwaukee, these are all the splint support for the scoliotic patients. Then we have next one, this one. What exactly is this? This is Aeroplane Splint, and where do we use it? This is used for all the patients of brachial plexus injury. This is used for the injury of brachial plexus injury, right? That's for the brachial plexus injury. So whenever there is an injury like that, you don't want the patient to keep the arm adducted so that there is no contracture, and therefore we are using it. Similarly, in the lower limb, we have a splint to support the droop of the foot whenever there is a compression of what condition I can say you can use it. You can use it whenever there is a hit to the sciatic nerve, and the sciatic nerve is usually hit in which condition we read? The posterior dislocation of the hip, or simply the involvement of the common peroneal nerve, which occurs around the knee area, the proximal fibula area. So all of this, you know, the CPN or the sciatic nerve, this is going to lead to what? The failure of the motor power in the lower limb, that is foot drop, and therefore whenever the patient tries to lift of the leg, it will just droop down, and to support it, there is a splint like this which can be given, right? That is a foot drop splint. Okay. Then we have the common splints used for common kind of nerve injuries which are frequently asked in our exam is a knuckle bender splint. This is knuckle bender splint. What exactly is this used for? So here you can see the knuckles are being bent to get the length for the fingers, right? So this knuckle bender splint is basically used for the opposite kind of deformity. When the knuckle bender splint is like this, it is hyper, extension of the MCPs and flexion of the IPs. So that is what we discuss as or describe as, the claw hand. So either it is a ulnar claw hand or it is a medial claw hand, we are going to use it, right? Ulnar or the medial claw hand, we are going to use the knuckle bender splint, right? We are going to use the knuckle bender splint. Next one is the cock-up splint. You very well know why to use it. So cock-up splint is basically used for whenever there is a failure of extension of the wrist or the finger. So wrist or finger drop, and you know that these are seen basically because of involvement of which nerve? The radial nerve. So this cock-up splint here, what you can see is in this particular cock-up splint there are springs attached, and that is why it is known as a dynamic splint, because what it does, patient is having a problem in extension. So the splint keeps the fingers in extension like this, and you ask the patient to go for flexion like that. So patient has get a way in which he can have a regular exercises of the involved muscles. So flexion he can do, extension the splint will do. That is why you call it dynamic splint. Okay, that's why you are going to call it the dynamic splint. Then another kind of splint that we use is a Dennis Brown splint, and where do we use it? This Dennis Brown splint is used in the cases of the congenital talipes equinovarus, where two shoes are connected to each other by a bar, right? And the distance, the length of this bar basically is equal to the distance between two shoulders, is equal to the distance between two shoulders of the child, like that, plus 1 inch between two shoulders, and we just add 1 inch, so that the patient can have a picture in the mind that everything is going fine. There is no legs, they are coming adducted or abducted, they are not running here and there. So the equal the length of the bar will be equal to the distance between two shoulders of the child plus 1 inch. Okay, so this is how we give the CTV splint. This is how you give the CTV splint for the this Dennis Brown splint. This is only given when once the deformity has been corrected. Once the deformity has been corrected, and you know that how the deformity will be corrected. How the deformity will be corrected in CTV? What is the sequence of correction of the deformities? The order of correction has to be cave, right? And who gave this kind of method? It is what you call as the Ponseti technique. So all the time when you are giving the Ponseti, by Ponseti technique you are giving the cast CTV, the braces basically. So you know that how to assess for the correction achieved with each plaster cast. The correction assessment is done by the scoring system, which is what you call as the Pirani scoring. It is what you call as the Pirani scoring, right? Cave, correct, absolutely true. It is a cave deformity. So cave sequence, not the deformity. It is a cave sequence, the cavus, adduction, varus and equinus. That's how you treat it. So with the each plaster cast, whenever you are giving the plaster, you must assess Pirani scoring. If you don't know how to assess it, that's okay. Remember the name at least. And the person who taught us this method was Ponseti technique. So once the foot has been corrected, to maintain the correction, we are giving this Dennis Brown splint, right? So these are the commonly used normal splints that we see in our routine exams, routine wards, OPDs. Every hospital is having at least one day of the week which is dedicated for CTV, right? CTV clinics, okay? Because the plaster has to be changed almost every week. So these are the different kind of splint supports. These are different kind of the splint supports that we occasionally see in our routine practice, okay? After that, the second section of the same topic is the traction system. First of all, guys, we need to understand why we use any traction. Why are we using any traction? So basically, traction system, it is used to keep, simple thing, to keep the, or you can say maintain, to keep or to maintain the alignment of the bone. To keep or to maintain the alignment of bone, of the bones. So injured end, if two ends are injured, you just pull it, one counter traction like that, and so that the alignment can be maintained. That is the purpose of traction, okay? Now this traction, it can be given in two ways. It can be given in two ways. Either you give it superficially, you apply some bandage here and you pull that bandage. That is what you call a skin traction. And the second one is what you call as the skeletal traction. Through the skeletal system, you are going to give it a pull. So it can be skin traction or it can be simply a skeletal traction. That's how we can give the traction to align the bone, okay? Now when you talk about the traction system, the first of all, let me tell you the skin traction. This is a conventional skin traction, a normal traction which is known as Buck's traction. What exactly is this? Here the patient is lying supine. You all can see that. Patient is lying supine, hip and knee extended, and there is a bandage which is applied over here. And through this bandage, there is another bandage which is being pulled by this pulley over this weight, right? So basically, this is what you call a skin traction. You have wrapped something over the skin and you are pulling that bandage to maintain the traction. So this can be basically used to maintain any kind of traction which is required for femur area, thigh area bone, right? Like that. So this is, or to correct some sort of deformity in the children's. That's what you call a conventional skin traction. So you must remember that normally, speaking, they may sometime ask you that what is the maximum weight that can be, given for the traction in the skin traction. So maximum weight is like almost you can say 15 pounds. So in the pounds it is given and it comes to be almost close to 6.7 kgs. That is the maximum weight allowed. The maximum weight to be applied for a skin traction is almost like 6.7 kgs, close to like 6.8, 6.9 is 15 pounds. That is advisable. Okay. So this is, you just wrap something around the, okay. So, Namaste Govind, how are you? Okay. Anu, I have already taken up that question. You go to the previous part of this video, or otherwise you can also go for the recall videos. There I have recalled all the questions as have been given to us by the student and I have discussed everything, right? So please go through that videos. Still you need any assistance, do let me know. Okay. So skin traction, this is one, what you call a skin traction. Simple. What is the skeletal traction? Simply, skeletal traction simply means that you are putting something through the bone Skeletal traction simply means that we are putting something through the bone, and that appliance which is inside the bone, right, is being used to give traction to the injured area. For example, the most commonly used appliances for the skeletal traction, it is what you call the Steinman pin, number one, upper one, and the second one which is Denham's pin, right? What is the difference between a Steinman pin and a Denham pin? The difference between the Steinman and Denham is Denham pin is having threads in between, as you can see in the insert picture, right? Why it is so? Because this the Steinman pin, when you see, it is sharp at one end and it is the other end which is being fitted into the drill area. So when you put these pins, these are very smooth pins. The surface is very smooth. So if the bone in which you are putting it, if the quality of the bone is very poor, like for example, an osteoporotic bone, now what is going to happen? For that osteoporotic bone, what will happen is this pin, which can easily slide here or there, like that. It will keep on moving, sliding here and there, right? But in the case, if you put a Denham pin in an osteoporotic bone, what will happen? These threads are going to stay inside the bone. They don't move. They don't have the power to slide now, because these threads, they don't allow it. Okay, so Denham's pin, when we talk about it, it is being used in osteoporotic bone. So these are the most commonly used appliances which can be passed through the bones, and after passing through the bone, what we do, this is what you call as bowler's stirrup. That's what you call as the bowler's stirrup. So what we do here, this is the pin, okay, and this is basically through the bone. So you can say if it has been put in tibia, so this pin is now basically passing through tibia, like that. Okay, and now what we are going to do, this pin has been passed, this pin will be attached to this bowler stirrup, like that. You will tighten it with the screw, and then from here you are going to put some weight. So you are pulling now the Steinman pin through this bowler stirrup. That's what you call as bowler's stirrup. Okay, so this is an appliance again which can be used to give skeletal traction. Now these are for the basically bigger bones, the Steinman pin, Denham's pin. What about the small bones like phalanges? If you want to pull it, give a traction, so we can very well simply use K-wires as well. For the phalanges, metatarsals, metacarpals, we can very well use the K-wires also to give some sort of traction. So Steinman pin, Denham's pin, and K-wires. These are the three things to be used, the bowler's stirrup. Now when you give a traction, sometimes it is also required to have a counter traction. Now this counter traction can be like fixed traction or a sliding traction. What does that mean, fixed or a sliding traction? You see, in this image, if you observe, a patient is there who has been applied a Thomas splint. Like this was a Thomas splint. All of you can recognize it. Okay, and then from this Thomas splint, you can see in the leg area there is a bandage applied, and through this the bandage rope has been applied and tied to the end of the Thomas splint. So basically this is what you call a fixed splint. What do you mean by fixed splint? Fixed traction splint or the fixed splint. So basically fixed traction means this Thomas, which is now being used to stabilize the bone, now which is fit here in the groin area, this bandage which is on the skin, through this you are trying to pull the leg down, but this Thomas doesn't come down because it is now fitted here into the groin area. So this is a fixed traction method. There is no increase or decrease in the weight which can be done. That's what you call the fixed traction. That's what you call the fixed traction. Okay, this is a fixed traction. And the other one which you call a sliding traction is, what we do in the sliding traction, here you can see you have given a flexion piece at the knee area. Okay, and now the weight of the patient here, the weight of the patient is giving you a counter traction. So you are trying to pull from here, and the weight is behaving like a counter traction. So the different types of tractions that we use in orthopedics, they are like this: the gallows traction or the Bryants, which are same, which are used for fracture shaft of femur, and all the other ones. Let's see some of them. This is what you call gallows traction. The hip remains, basically it is given for what condition? It is given for fracture shaft of femur in a child. What age group of child? When the age of child is almost, you can say, less than 2 years, and we always say that when the weight is less than 15 to 18 kgs, like that. Okay, this is how you give. So all the time the weight has to be very less, like less than 10 kgs or so, but it is not given in any of the obese children or more than 2 years of age, right? That's how you give it. So now this hip, basically when the two legs are tied to a overhead beam here, like that, okay, and this hip is kept off the couch so that there is no ulceration onto the skin. So that's what you call the gallows traction or the Bryant's traction used for the fracture shaft of femur in a child who is less than 2 years of age. Okay, this is what you call Hamilton-Russell traction. A simple, fracture shaft femur here you can use simple splint on the leg area and then a traction like this. Okay, and some knee pieces are always added to it. This is what you call the Bowler-Braun frame. See this, there will be a pulley over here, there will be a pulley over here, and there will be a pulley over here like that. Okay, so you can use for the calcaneal traction like this, you can use for the femoral traction, you can very well use for the tibial traction like that. So this is a Bowler's bone frame, the Bowler's bone frame. Okay, so this is being used basically for making it a sliding traction. Okay, it is basically made to use for a sliding traction. And then we have one more. This is what you call Dunlop traction, and I do believe most of you might have not even seen it because this is an old modality of treatment. We don't use it nowadays. So here these Dunlop traction, they are being basically used for the fracture supracondylar humerus in past. Nowadays we don't use it. Okay, but in olden times it was a fracture shaft of humerus. Okay, so these are different types of splints and traction, and this is what you call the Barton's tong. We have the Crutchfield tong, we have the Barton's tong, we have the Crutchfield tong, which are basically used for giving traction to the cervical spine, So Barton's and the Crutchfield tongs, these two are the main ones. Okay, these two are the main ones to give the traction to the cervical spine. So here in the parietal area, basically we introduce the pins, and from here we are going to pull some weight like that to maintain the traction and to maintain the alignment of the cervical spine. These are the ones. Okay, so guys, these are different splints and traction. Do let me know if you want me to teach you something special. Okay, like Anu Kalotra said about the last year NEET question about Elizaro. So first of all, for that, my dear, let me show you Elizaro, how it looks like. Okay, let's see the orthopedic instruments, and I'll show you first of all how the Elizaro looks like. I do believe all of you already have the idea. So let me just show you the Elizaro. Elizaro is this one. Okay, this is Elizaro fixator. You all know this. This is Elizaro fixator. So here the olive wires are passing through the bone in all direction, like this, like this, like this, like this. So basically it is giving you the stability in all the directions. Okay, it is all around the bone. It doesn't allow any kind of movement on the fixed area. Other than that, the most commonest use external fixator we have is JES. This one is JES, the Joshi External Stabilization System. Okay, that is Joshi External Stabilization System. It is a smaller, it is used only for the small bones, Joshi External Stabilization System. Okay, and then we have this one which is known as LRS, the Limb Reconstruction System. Okay, Limb Reconstruction System, or also known as the rail fixator. Yeah, Kirti is very much right that it is used for distraction osteogenesis. Absolutely true. Distraction osteogenesis, or you can say simply the limb lengthening, like that. In cases of osteomyelitis, we can use them. So this LRS, basically these are external fixators which are used for primarily for open fractures, open injuries. Okay, these are primarily used for open fracture or open injuries. Okay, so LRS. And if you talk about the biplanar kind of the simple rod and clamp, these are the simple rods and clamps. Okay, these are the pins which have gone into the bone. You can see these pins are going into the bone. There is a fracture over here, there is a fracture over here. So 3 pins here in the distal part, 3 pins here in the middle part, and some pins on the top part, and then these pins are fixed by these rods and clamps, so that now there is no mobility between these injured bony fragments. These are the different external fixators. Now looking at this, this is only giving you the stability in one direction, while Elizaro was giving you the stability in all around, every direction. Okay, that was the difference. That was the difference, right? So these were the different external fixators we have available with us. Now let me know, guys, what else you want me to tell you from orthopedic part, so that we can move it, make it a very fruitful, important, and crisp, concise kind of discussion. Okay, so I do believe that these 2 files, the PDFs, the instrument, implant, splint and traction, you already have downloaded from the different groups. As I said, please keep them safe with you. Before going for the exam, just go through them once, so some of the appliances can be asked. So these are different external fixations. Okay, so this is one. Now when I talk about the other, instrument implants, these are retractors. And if I tell you about this one was in your exam, the Morris, almost if I'm not wrong, like 2 years back, they asked at the Morris retractor. This is being used for bigger surgeries, abdominal surgeries, general surgery field, and these are the ones with smaller blade, the Langenbeck and the Zerny. Okay, Langenbeck and Zerny. These are different kind of the retractors which are used in surgical field. Okay, and the other one important one instrument implants will be like this one, crocodile like mouth. This is nibbler. Okay, that one is nibbler, and we have these are, you already know that which nails are these. The angulated nerve, the nail basically is always a tibial nail, and this curvy nail is always a femoral nail. So tibial nail and the femoral nail. Okay, these are simple K wires, you already know about it, right? These are K wires. And then you have this, which one? Yeah, this one is a stainless steel wire. Where do we use the stainless steel wire? These are used for the tension band wiring method. These are used for tension band wiring purposes. Tension band wiring purposes. Where do we use this or do this tension band wiring? So this is being done in fracture 2 part of patella or the fracture olecranon. These are the two most important areas where you can very easily do that. Other areas are also there, like medial malleolus and so on. So we can do that. And other than that, the ones which are very, very important, the number one is this periosteal elevator, right? So why do we use it? Simply to raise the periosteum. Okay, and similar to this end, there will be this one which is chisel, but the difference here, we don't have any thumb rest. How to differentiate chisel from the osteotome? This is the osteotome which is sharp at both the ends. This is the osteotome which is sharp at both the ends, and this one is sharp at the lower end and bevel at the upper end, like that. Okay, this is what you call a chisel and a osteotome, the chisel and osteotome. So these are the different ones. These are the different ones, important ones which you should know. These are what? The tense nails. Where do we use them? The fracture shaft of femur, shaft of tibia, the long bones basically in a child. So what does that TENS stands for? The TENS is titanium elastic nailing system. It is the titanium elastic nailing system. Okay, that would be titanium elastic nailing system. TENS nail. That would be TENS nail. So this one, another one is what you call as DHS. And where do we use it? For the fracture intertrochanteric or simply the basis cervical fracture of neck of the femur. There we are going to use these implants. So okay, and these are the simple DCPs, you already know. DCPs and the LCDCPs, the locking plates. Locking plates are better in osteoporotic bones, right? So these are the different ones which we have to discuss. So these are all instruments, implants, splints, traction in short from my side. Okay, and if I show you some other clinical cases or clinical presentation, I do believe everybody knows that what exactly is this machine. This is what you call a CAM machine, right? This is what you call a CAM machine. And why do we use it? For close reduction and internal fixation. Okay, if you can diagnose this patient, if you all can see, can you comment on this? What exactly this fellow is having? What exactly this fellow is having? Can you comment on that? So if you just see at, okay, if you just see, look at the shoulder, what are you able to observe? Can you see the right shoulder is having a proper contour? Looking at the left shoulder, what do you see? The prominence over here, and this prominence over here is of the acromion. This prominence here is of the acromion, isn't it? And the fellow, he is standing with his arm abducted and like almost externally rotated. What exactly is that? This is anterior dislocation of the shoulder. That's your anterior dislocation of the shoulder, right? This fellow is having anterior dislocation of the shoulder, right? And this was the picture I was talking about, that this is a kind of X-ray which was given in this recently conducted exam, and they asked you that why this external fixator has been given. So here the fixator has been given in tibia as well as in the femur. So obviously when it is being given in two bones, upper and lower, it simply means that there is something wrong in between, right? In the periarticular area of the knee, it is wrong. So we have to be vigilant while we are attempting the questions in our exams, that these are the different kind of appliances which can be frequently asked and have been asked in last couple of sessions of our exams. Okay, so these are the ones. Anterior shoulder dislocation, Kirti Krish is absolutely correct, right? You're absolutely right. So these are the different things, guys, I wanted to discuss with you. This is just a list, okay? And yeah, and let me just show you another thing. Okay, and if I show you certain angulations, one angulation which I wanted to show you from the recently conducted examination was like this. That's what you call as the Cobb's angle, right? Upper part of upper breast vertebra, lower part of lower breast vertebra. So that's what you call as the Cobb's angle. This is what you call as the Cobb's angle. Where do we use it? To assess the scoliotic deformity. To assess the scoliotic deformity, right? These are, you can see these X-rays. These are, you know, biplanar, in fact triplanar, this rod and clamp which have been given. So they will be having somewhat more stability as compared to the any of the other uniplanar or double rod uniplanar kind of fixator given, right? If you just see, yeah, if you just see, I had one another very yeah, okay. If you ever see this kind of picture in your exam, if you ever see this kind of picture in your exam, so what you are going to make out, so what are these round appearances you can see? What are these round appearances you can see? These are antibiotic beaded bone cements. These are antibiotic bone cement, and this is an implant, right? So basically this, you can see here we have a fellow who is having a defect in the bone over here, and that's a case of actually chronic osteomyelitis. The implant is still there, somebody has tried to put a bone graft and all. So this is how any of the patient is going to present to you if an antibiotic impregnated bone cement has been used. Okay, so these were some of the special cases I wanted to discuss with you guys. So these are special X-rays, PMMA, very good. Kirti is very quick and accurate. That's very quick. Okay, and this last image I am trying to show you, it is a Rizer's cast. It is a Rizer's staging basically, and that is used to assess for the skeletal maturity. That is used to assess the skeletal maturity. Okay, that is used to assess skeletal maturity of the child for scoliosis. That's what you call Rizer's staging. Okay, so I had only these points, guys, with me today. The splints, tractions, instrument, implants, like that. So these were the only things I wanted to discuss as of now. Okay, if you want any of the academic assistance from my side for orthopedics point of view, feel free to just connect with me anytime you want. Okay, I am very much there on the social media networks, on the medical Facebook of eGurukul, on the DBMCI Premier group, on my orthopedic discussion group. So you can just post a question about orthopedics, and you can very well connect with me wherever you want, right? So these were the simple things, guys, I wanted to discuss with you, right? Thank you so much for being a part of the session. Okay, and if you have got any doubts, all the time, you are most welcome. Keep preparing well, stay happy, stay healthy, all the very best. Thank you so much.